Hello, thank you very much for the kind of invitation. I'm going to talk about sclerotherapy, past, present, and future. I do not have any conflict of interest. The man who is here in the picture is Hippocrates. He started to talk about to treat tortuous vein with sclerosis in order to avoid ulcer formation. He also described the term scleros, and it means to cauterize with an ultra-hot iron the vein that causes the ulcer. The man over here is Johann Herschel, who was the first to puncture a vein in a soldier's leg ulcer using an ad hoc instrument, working as a syringe made with a pig's bladder. The man over here is Charles Pravat. He invented the hypodermic syringe and started to perform effectively sclerotherapy. And the sclerosant that he used was ferric chlorate. The first sclerosis treatment were performed in liquid solution. And until 1915, that started to describe the Raymond Tourné in France, the thrombectomy, and in the same year, Carl Sieg started to describe his own method of sclerotherapy and started to treat the saphenous trunks. Then appeared Sicard with sodium bicarbonate and sodium salicylate, and he started to publish the first treatment with sclerosis. Then appears until 1927 the hypertonic glucose solution, and in Germany, Paul Linzer with hypertonic saline solution. Then in 1933 appears the chromic glycerin, very common using in the treatment of telangiectasia. And then we start in 1946 the tetradecyl sodium sulfate in Germany with Rainer, and in 1966, 20 years later, the polydocanol appears. And what about the FOAM? FOAM started in 1995 with Juan Cabrera in Granada, Spain. He started to mix in a homemade FOAM sclerotherapy, mixing CO2 and O2. And then Lorenzo Tesari showed us in 1999 his method, mixing two syringes with a three-way stopcock and performing the FOAM with a ratio of oxygen 1:2. Then Frulini and Shadek started to talk about ultrasound-guided foam sclerotherapy in Cabesi with catheters. And during almost more than 10 years, Shadek showed us very carefully the ultrasound-guided foam sclerotherapy. 2007 started to talk about with chlorhydratro of Lapidium, the ultimate detergent appears in the market until 2013. That appeared the Varitena. It is an industrial polydocanol foam. And then in 2014 we started to talk about the modern era of intravenous ablation, and non-thermal, no tumescent techniques allowed us to speak with ultrasound guided foam sclerotherapy, PEM, microfoam standardization polydocanol, this is Varitena, and the MOCA, mechanochemical ablation with Clarivane and Flevogriff. So what do we have to do in the present? We have to perform an ultrasound previously to any kind of treatment, verbal and written informed consent signed always, photo documentation pre, intra and post procedure, low dose of foam per session, no more than 10 to 12 cc of foam. Gases, we prefer to perform ambient air and trying to get the better and functional and aesthetic results always. We can use augmented reality, transdermal illumination, and ultrasound guided with high frequency transducer to achieve better results. This is a review of randomized controlled trials compared ultrasound guided foam sclerotherapy with endothermal ablation for the treatment of great saphenous vein. The thermal techniques present best anatomical success than ultrasound guided foam sclerotherapy. They present the same clinical success as thermal techniques, and also they present the same morbidity and complication after 5 years. But regarding to cost effectiveness, thermal tumescent techniques are lower than ultrasound-guided foam sclerotherapy. What about at 6 months? Foam is cost-effective regarding to this historic comparison of laser surgery and foam sclerotherapy, the class randomized controlled trial. And at 5 years, endovenous laser ablation is cost-effective, followed by foam and sclerotherapy. So sclerotherapy at 8 years has 51% of occlusion rate, and symptom-free at 8 years it's 55.1%. But what do we have to do to perform and to improve the occlusion rate of foam sclerotherapy? We have to aggregate a device that induces a spasm in the endothelium plus foam. This performs synergism. Synergism is called MOCA, the Maradona trial radiofrequency ablation of the treating primary great saphenous vein incompetence. It's compare radio frequency versus MoCA in 2 years, but the post-operative pain is the same. It's a faster venous stability improvement. A 2-year follow-up, there is less hyperpigmentation in radio frequency, but more in MoCA and more anatomical failures in MoCA technique. This is the last LAMA trial published this year in January. Is comparing the venous laser ablation with MoCA. They have very similar clinical severity outcomes. It is a safe technique, very similar peri-procedural pain, but at 1 year follow-up, the MoCA has more anatomical failures. What about the economic aspect? The economic aspect reveals that the ultrasound-guided phone sclerotherapy is the best cost-effectiveness technique in the market. What about this? A 5 years outcome of Clarivane. Clarivane show us that at 5 years the failure is 70.7% freedom of anatomical failure. The venous clinical severity score was significantly improved. And the other MoCA technique is the cutting catheter-assisted phone sclerotherapy, the Flebograph. At 2 years, the rate of occlusion rate is 92%, and it is a safe technique also. This is the reunion that had been held in 2019. The Mayo scientific event was held in the global line of trends and controversy in the lower venous and lymphatic disease narrative literature revision and expert opinion, following the big winter international meeting in phlebology, nephrology, and aesthetic in last year. And what about the MoCA? MoCA started in UK NICE techniques, and in European venous success in 2014. And in the United States, they have a grade of 2B, and in LATAM guidelines, a grade of 2A. What about the European College of Phlebology guidelines for pharmaceutical ablation that was published in this year? They show a patency rate of 62.8% of occlusion. I'm sorry, patency rate, not occlusion rate. And the MoCA, we've got 87%, but we do not have data at 5 years. So we have to wait for the results. This is non-thermal and non-tumor set current techniques in international astrology this year. Ultrasound-guided phone sclerotherapy is 1A, and MoCA waiting for the long-term result until now is 1B. So as conclusion, each group of authors used their own variation of their own method, describing in the published literature with good results. It is clear that phone sclerotherapy is far more effective than liquid sclerotherapy, and that ultrasound imaging allows the treatment to be delivered accurately to the affected veins. New global guidelines and phone sclerotherapy consensus in the treatment of superficial venous insufficiency should be done. All the societies, all the venous forum, etc. This is the future. So, phone sclerotherapy is an excellent option to treat any kind of venous affection, and is cost-effective procedure, cheap and repeatable. New devices, catheter, and MoCA procedures, etc. should be arised to perform a low-cost procedure in the future. Thank you very much for the invitation. I want to invite all of you to our Congress in Buenos Aires next year, that is going to be held the IUP World General Council meeting. So this is it. Thank you very much for your time.